What is going on, YouTube? Welcome back to another episode on CellMed. And today we have episode number 5 of the MEDview series, where we're going to be speaking to our very first physician on the channel, Dr. Rameez Rehman, who is a second-year interventional radiology resident in New York. And he also has his very own YouTube channel, which I will link in the description below. So as always, just a quick rundown of the biography of our speaker. Dr. Rameez Rehman was born and raised in Brooklyn, New York, and attended medical school at St. George's University School of Medicine and was part of the Global Scholars Program in the United Kingdom. He did his internal medicine residency in New York and is board certified by the American Board of Internal Medicine, and he also practiced as an attending in emergency and internal medicine in New York City. He is currently training as a second year in diagnostic and interventional radiology. Without further ado, let's go ahead and let's see what Dr. Rameez Rehman has to say about the field of interventional radiology. Hey, assalamu alaikum, Rameez. How are you doing?
Walaikum assalam. How's it going, man?
Good, good. Thanks for being on the channel today. Is there anything that, anything that you want to share about yourself, about who you are?
Yeah, for sure. So, I mean, again, thank you for having me. I really looked at some of your work, and I think it's a really good platform. Definitely, it's very informative for prospective students, and I'm really glad to have the opportunity to kind of contribute to it. Not only am I a doctor, I'm alhamdulillah married. I have two kids, mashallah, and a third one on the way. So, besides just being a doctor, I also am a husband and also a father as well. So, kind of learning as things go.
Okay, congratulations, congratulations. That's great to hear. So the first question that I always hop into with the interviews is, what led you to be interested in the field of medicine?
Yeah, and that's like the most infamous question, right?
Yeah.
So actually, yeah, the way I kind of looked at it, how I landed on medicine was a little different than how usually people land on medicine. I didn't really have a particular interest in medicine in general. I was a very technical, mechanical type person. I was really into engineering, architecture, and things like that. And the type of personality that I have is whatever I get into, I always try to be really good at it. So whenever you do that, it takes time. And one of the reasons why a lot of people disqualify medicine when they're thinking about a career choice is they're worried about the time commitment. But the time commitment wasn't an issue for me. I always knew that whatever I was going to do, I was going to put in a lot of time. I really wanted to be good at it. So that kind of left medicine on the table for me. And then as I was, more into looking behind the scenes of how things are built, how things work, I started thinking about how, everybody has a body, but but everybody's different. And I started thinking that if I'm going to dedicate my life to learning and trying to be a master of something, I want something that's not man-made and something that's really, beyond our scope. And that's how I landed on, I want to learn more about the body. And then from there, I started getting into, I want to be able to treat diseases that affect the body. And then from there, I got into, I want to do procedures and actually manipulate the body for a good outcome. So that's kind of essentially how I landed on, I think what I'm going to do is I want to be a doctor. And then not only do I want to be a doctor, I want to be a procedural oriented doctor. And that's kind of essentially how I landed on medicine in particular.
Okay, that's great to hear. So something that you mentioned on your channel, and for those of you who haven't checked out Dr. Rahman's channel, it's the Rad Med, and I'll put the description in the link below. And something that you mentioned was how you were successful as a medical student. And if you were to list 3 things that one could do to be a successful medical student, what would those 3 things be in your opinion?
Right. Yeah. And that's one of the reasons why I really like platforms like this. Back when I was a medical student, really the only way to get information about becoming a doctor was to speak to other doctors and get insight. You had to go to the hospital, you had to hunt them down, you had to ask for permission to spend time with them. And now with resources like this, I really like the fact that doctors are easily able to share their insight. So if I was to speak to prospective medical students, which I do, I mentor a lot. I appreciate the fact that you plugged my channel there.
Yeah.
The rad med. So I do radiology and I'm board certified in internal medicine. So I practice both currently. So 3 things that I would tell prospective students. Number one is you have to really medicine really is a marathon, and you have to put that in your mind early on. So all the stuff that you learn from the foundation, from the basics, you will be astonished that 4, 5 years later down the road, those things really do come back. So when you're a medical student, you really have to focus and take the foundations extremely, extremely seriously. You really are building the foundation of a house, and that's really what's going to build the rest of your career. And it's very easy for us to only think about ourselves, but in reality your career really depends on what's going to happen with your patients. So the amount of effort that you put in early on pays crazy dividends down the road. Number two, when you're a medical student, you really have to put yourself out there, and you cannot be afraid to put yourself out there. And not only to other clinicians and other doctors, because that's your goal and you want to become a doctor, you have to be open to ask questions to the right people. For example, you have to open up to nursing staff, ancillary staff, learn as much as you can from whoever you can. And you have to be not afraid to ask questions. The first time I learned how to place an IV, a resident didn't teach me, a doctor didn't teach me. I learned off of a nurse. The first time I learned how to draw blood on a patient, I asked the phlebotomist, hey, you mind? I don't know how to draw blood. Can you show me? And that's the skills that I learned. And when I became an intern, in typical New York City fashion, I was drawing everyone's blood all the time. So it was good that I had the insight to kind of ask these types of questions. And then third advice I would give to students is just, you have to be passionate, and you have to be motivated, and you have to really be prepared that this really is a long journey. So don't forget, why you're doing what you're doing. At the end of the day, be passionate, and when you're passionate about it, naturally it's gonna show. And that's the only way to separate different levels of medical students versus residents, and that's really the way it's going to come out to everybody, not only your patients but also your staff. So just, you have to know what you want, and stay motivated, and just be passionate about it.
Okay, so you mentioned that you were board certified in internal medicine and now you're pursuing interventional radiology. So, what was that decision algorithm for you to say, like, why you wanted to go into IR?
Correct. Yeah. So I'm not crazy, although a lot of people sometimes do feel that way. Especially if you talk to my wife, she'll feel that way. So when I was in my second year of internal medicine, we were consulting with radiology so much. Radiology is a very tricky field because it's not one of the cores in medicine. So you don't get proper exposure to radiology unless you have some kind of insight, unless someone tells you about it, or you happen to have an easy opportunity to be able to seek a rotation in radiology. You don't really get that much exposure to it. I got my first exposure to radiology when I was a fourth year medical student doing an elective after I had already matched into internal medicine. And then as I was progressing through my training of internal medicine, we consulted with radiology so much. I went down to the reading room so many times for the care of my own patients. And then in particular, IR is a fascinating field with so many different facets when it comes to patient care. A lot of my patients were being managed with IR. So as when I became a second year, I decided, you know what? Instead of pursuing traditional fellowship in medicine, I thought about, you know what? Maybe I'm going to pursue interventional radiology. Now, backtrack one thing also is that during my internal medicine training, I was very procedurally oriented. So all the central lines in the ICU, as many procedures as I could do, I learned them, a lot of them during my intern year, and I just kept mastering them. And I really would stay late. I would do procedures for my seniors who didn't want to do procedures. So I was very procedurally oriented to begin with. Then when I became a second year, I decided, you know what you have to do a lot of like searching within yourself and be honest with yourself. The closest field to something like interventional radiology is like interventional cardiology. I applied for that. I was actually in the match for that because I was afraid that, just in case if I can't match into radiology, given the fact that I'm already going to be training. But I dropped out of that match because I didn't see myself doing cardiology for 3 years, just so then I can do interventional cardiology. So I decided if I'm going to pursue a career, I might as well take what I learned in internal medicine. IR is in such a state of transition, and it's still trying to discover its identity. So I felt like having a solid clinical background, you can't ever go wrong with that. That's one big advantage of why I think people should consider going to internal medicine, because for 3 years you are a general doctor and you kind of get involved in every aspect of patient care. So you build a really nice foundation, and that can really be applied to any specialty. So when I became a second year, I reached out again to a mentor. He was the interventional radiology, the chair of that department in my hospital. He didn't know me. I didn't know him. I sent him an email. I got his email, sent him an email. He told me, you know what, come to my office now. I sent him an email saying, I would like to speak with you. He had no idea who I was. I literally knocked on his door, introduced myself, and then from there, now I'm here, second year into my training.
What traits in your opinion, does like one need to have to be a successful IR physician?
Gotcha. So that's a really good question. So with IR in particular and radiology in particular, because in order to do IR, your prerequisite almost is that you need to be a really good diagnostic radiologist. So one trait is like you need to really appreciate the anatomy, love anatomy, and that will make you a really good diagnostic radiologist. And without having the skills to interpret images on a very high level, you're never going to be able never be able to be a good interventional radiologist. So one trait that you need for sure is that you need to be a master of anatomy and be really good at diagnostic radiology, right? And then secondly, what I would say is you also have to accept the fact that radiologists, many times they work behind the scenes. IR, like I said, is changing, but again, it's mainly it's a consult field. So you're never going to be in the front line. You're never going to be that hero. And you have to be okay with that. You have to be okay with being the doctor's doctor. You know that majority of the time, other doctors are going to reach out to you for problems that they're having, and you're going to help the doctor solve the problem. But the patients may not, be able to give you that glory. So you're not going to be that doctor that's going to be on TV and everyone's going to love that doctor. But you have to be okay with that with yourself, that you're not going to be the frontline hero. Like I said, IR is changing. That may change, but as of right now, you're not going to be the frontline hero, and you have to be really secure with that decision of being the hero really behind the scenes. So being secure with that will definitely make you a good interventional radiologist and just a great radiologist in general.
It's interesting you say that though, is because I listen to a lot of different podcasts where, specifically specialty stories with Dr. Ryan Gray on Apple Podcasts, and he interviews quite a few interventional radiologists. And what it seems like every time they say is like interventional radiologists are the people that when you don't know how to treat the patient, you always send them to IR.
Yeah, yeah,
So
yeah.
so I definitely feel like IR is definitely, once people start to recognize what IR can do, I think it'll really start to earn its name based on what you guys do. So I think it's something that's coming in the future.
Yeah,
Um,
absolutely. I mean, that's one of the great things about IR, and then that's why in order to be a good IR physician, you have to be really patient because the cases that you do get are usually the most complex cases that are,
right.
are not able to be done, or sometimes too difficult to be done, maybe because the patient's health, or maybe because technically it's just becomes too difficult. Like I'll give you just a quick anecdotal story. Just happened recently. Is there was a case that urology had worked on this patient 2 days prior before this patient had come to IR. We knew urology had attempted to do this procedure and they were unsuccessful. This guy was a pretty complicated case. When I was consenting the patient, I was speaking with anesthesia. This is pre-op before the case. Me being the resident, he just jokingly he told me, "Hey, look, I watched two of the best like urologists that we have in this hospital spend like 3 hours, and I'm telling you right now, like this is just it's not going to happen. Like I know they sent it to you, but this was a really tough case." This was the anesthesiologist telling me that. And yeah, you know what? That he could be right. That happens. Sometimes cases are just extremely tough. My IR attending came. Me and him, did the case. My IR attending, fantastic skill. And somehow 2 hours later, he was able to do what these urologists were not able to do. And the anesthesiologist afterwards told me, he was like, that was awesome. I didn't know that IR was even able to do that. So even physicians in the field are still like understanding the capabilities that IR has. And so that's why I feel like it's a very exciting field to get into.
So speaking about the patients, what are some common patients that you see, like the different pathologies, different complications? Like what are the most common ones that you typically see in your job?
Gotcha. So my job is kind of split up into two facets right now. It's a diagnostic portion and the interventional portion. When I'm on the diagnostic portion, I basically see anything and everything, just about any pathology that walks into the hospital. Almost everybody gets consulted with radiology. So any organ system, any age group, women's health, children, adults, all different types of pathologies, surgical and medical, I see when you're on diagnostic radiology. When you're on interventional radiology, things are a little bit different. And interventional radiology is also split up kind of in two general facets. Half the work that interventional radiology does is about diagnosing conditions, meaning taking actual tissue biopsies of various different types of tumors. Sometimes people have abscesses and infections that need to be drained, placing ports into patients' chests so that they can get chemotherapy for treatment. And then the other facet of interventional radiology is all the endovascular work that we do. So that means like placing filters. That means doing things like thrombectomy, for patients who have pulmonary embolism, or doing peripheral work for people who have clots in their veins. And then there's a whole field of of IR that deals with cancer. So we do a lot of work actually on embolization, which is actually preventing bleeding in traumas and just gastrointestinal bleeding. But then we also do something called radioembolization, which is in the blood supply of a cancer, placing small beads that have radioactive material in it. So you're basically trying to kill the cancer from the inside out, for long-term management of different types of diseases. Then there's liver diseases. Then you could talk about interventional neurology. So there's a whole field when it comes to stroke and stroke management and how that's changing. So basically, there's two facets of IR: what we can do with, small incisions made outside, and then what we can do by hijacking. I say hijacking, but by taking over the actual natural system that our body has through an endovascular approach. So basically, essentially, what we do all day is we do minimally invasive surgical procedures.
So, as a resident, what does a typical day look like for you?
Again, that also depends on what I'm doing for the day. So we get our schedule beforehand, and then you'll know if you're on diagnostic that day or you're going to be in interventional radiology that day. If you're on diagnostic, you come in the morning. We usually start off with a lecture, usually lasts for like about an hour. After that, you head to the reading room, and then you just start hitting the list, get it, as much experience as you can. And then you do that basically for the rest of the day. There might be some little procedures that come in between, fluoroscopic procedures, which are like a little bit lower level procedures. So you'll go see the patient, do a fluoroscopic procedure, and then you're back to the reading room. Throughout the day, you're speaking with all kinds of physicians, and that's one of the most fun things about radiology in general, is like the physicians will come down, they'll ask for your expertise, they'll tell you the story about the patient, they'll tell you how the physical exam is, you'll open the labs, you'll look at the images, you'll go through the whole process with the doctors, and you kind of are trying to help them. They come to you with a dilemma, and then your job is trying to help them. Now, when I'm on interventional, which sometimes I'm on that a little bit more frequently than I'm on diagnostic, day starts a little bit earlier. I come in the morning, I grab the list for the day. Usually, I know from the night before what cases we have planned up for that day. I'll go through all the imaging, go through all the labs. After that, we do like a quick rounds. We'll go to the floors. We'll see the patients that we're gonna do procedures on the same day. We'll see the patients that we did procedures on the day before. After that, we hit basically the IR suite, which is essentially our operating theater. We have multiple of them going at the same time. So from there, we see patients, consent them, go in, do the cases, and then back and forth, just going to do different cases. And then throughout the day, we have emergencies and various other things that pop up throughout the day that need our attention. And then a typical day basically starts like around 7, and usually you're done about 12 hours later, sometimes 6, 7. You'll usually wrap up everything and you're usually good to go. That's if you're not on call. Now, as a resident, you take call, and your call is an in-house call. So I just came off of a 24-hour shift. So I just slept before talking to you. And so that happens frequently throughout the week, maybe twice, 3 times a week. We'll do 24-hour shifts.
How do you find, of course, you're a resident now, and the work life balance might be a bit skewed from what you might have as an attending, but assuming that you would be an attending, what does a work life balance look like for an IR doc?
Yeah. So radiology, diagnostic radiology has a great uh, work-life balance and a great lifestyle, essentially because you're working a lot with images, a little bit less with patients. And maybe radiology might be the only field in the hospital that kind of can work on a set schedule, almost like a clock in, clock out. You can actually have like proper shifts. When you go into interventional radiology, lifestyle is quite different because you're covering emergencies, you're doing procedures, and things are many unexpected challenges arise when you're trying to help people. So in terms of keeping the balance, like I have a unique perspective. I wasn't attending for a dedicated attending for a whole year, and then I came back into training. And really, I think it really comes down to passion. Work-life balance, I feel like a lot of people stress about it. It's a good question, and it's something that people should address. It's normal to address it and maybe even be intimidated by not being able to keep a work-life balance. But if you're passionate about something, the work-life balance comes naturally on its own. So when I'm in the hospital, I really enjoy what I do. So while we're doing the cases, before the cases, after the cases, I really try to enjoy as much as I can. Uh, the craft that I'm doing and trying to get better at the craft that I'm doing. That helps me a lot in general, keeping my mood and spirits up, which helps when I'm outside of work. And then when I come home, I try to just turn off my mind, spend time with the kids. And then the other thing is you also have to work life balance is something that's dynamic. It changes because you're on different specialties, you're on different rotations, and then your life can just be a little different. So initially, when I started this residency, I used to go to work, come home, spend some time with the family, and then try to study. Recently, I realized, maybe that's not really working out for me. So I switched it up. So now when my shift is over at work, I stay at work for like another hour, hour and a half. I get whatever work I got to do. If I'm working on some research, if I'm studying, if if I'm reading something, doing some practice questions, I just mentally have extended my workday by like an hour and a half. And then when I come home, I completely disconnect from work. I don't think about work. I spend time with the kids and my wife, kids, I give them like my full attention. And I'm able to do it because I was able to make that sacrifice earlier on by just staying in the hospital. So you have to understand the work-life balance is something that's not like, you set it one way and it's going to stay that way. It changes. So you have to be willing to make the necessary changes for keeping a healthy work-life balance. But is it possible? Yeah, I mean, like I said, if you ask my wife, she might have a different answer, but I'll tell you it's possible.
So, what are some different pathways that one could take to IR from medical school?
Gotcha. So that's another thing. When I mentioned that the field is going through such a state of transition, the traditional pathway was you do an intern year, either in internal medicine or surgery. That's like your prelim intern year. After that, you do dedicated 4 years of diagnostic radiology. After you finish your diagnostic radiology, you would apply for fellowship to go into IR. As time is going on and as the IR procedures are becoming more and more advanced, now they started realizing that, maybe it's better to have doctors trained up front with interventional experience from the get-go instead of just being trained in diagnostics. So now there's pathways as of like, I believe like 2 or 3 years ago now, there's dedicated pathways where it's like a 6-year program and you match into interventional radiology just as you would match into general surgery or internal medicine. It's become its own separate specialty. Now, while they're still transitioning that, there's another pathway, which is if you're in a program that has something called an ESIR, which is an early specialization in IR, you do diagnostic radiology and scattered in between that, you do interventional rotations. This is exactly what I'm planning on doing, what I'm in now. My hospital has this pathway. Then you apply to become the ESIR resident. So your last year of diagnostic radiology residency kind of becomes your first year of fellowship, and you have more IR experience while you're going through your diagnostic um, residency. And then after that, you do a 1-year fellowship afterwards. Now, what pathway is better? Like I said, everything is so new. No one really knows what's better and what's not. The only reason why I chose the path that I chose is because everything is so dynamic. If you go into just a vascular and interventional radiology pathway, you're kind of just come out as board certified and you're a vascular interventional radiology trained physician. But if you go through this pathway, I'll come out as a diagnostic and interventional radiologist. So I'll be trained in both pathways. And like I said, my mentors that I've spoken with, they really say like if you're good at diagnostic, that really makes you a good IR doctor. So it's a little confusing for sure, but there's a lot of different ways to kind of get into the field.
So, the trends in medicine so far, from what it seems like, is interventional radiology is actually becoming one of the more competitive specialties up there with um, dermatology, neurosurgery. Like it's getting up there in terms of competitiveness. So, what can a medical student or even a resident do to make themselves competitive for this specialty?
Yeah, no, it's definitely I'm blessed to be in this pathway right now with the goal of becoming the ESIR resident eventually. Currently, I'm in my second year, and it's becoming extremely competitive because it's a new field almost, and people are really starting to understand the capabilities that IR has, and that's why it's just the popularity has definitely gone up. Well, like I mentioned earlier, one of the toughest things is that you don't radiology is not considered a core rotation, so you have to go out of your way to actually gain exposure to radiology. So as a prospective medical student that wants to go into radiology, I would say definitely, again, don't be afraid. Reach out to attendings, reach out to residents, reach out to hospitals, and arrange for yourself to be able to be exposed to radiology early on, like when you start your rotations. Build good relationships with doctors that are in the field, and that's definitely going to help you. Secondly, you have to really, this works for all fields, but in particular when it comes to interventional radiology, there's the main American society, which is the Society of Interventional Radiology. In there, they have various different branches of all different sides of interventional radiology. And they have so many resources out there for fellows, residents, and students. Definitely get involved, join committees. I'm part of like the critical care committee. I'm establishing a curriculum for future fellows. Given the fact that I already have an internal medicine background, you need to know medicine to be able to do these type of procedures and treat these patients. So I'm helping with that. I gave a webinar for this society to the rest of the SIR society. They have a lot of training opportunities where if you're a medical student or a resident, they provide fellowships for you to go to meetings. So far, I was lucky enough to go to 2 meetings and get two scholarships that way. I think the more motivation and passion you show for your field and your craft, I think that's what really is going to make you stand out. So definitely reach out early, gain as much exposure as you can, because that's the only way you're, first of all, you're going to know if this is really right for you. And second, if it is really right for you, then you'll be able to show future employers and everything else how dedicated you are to this field.
So correct me if I'm wrong, but from what I read from your bio is you're international, like an IMG, so international medical graduate. So do you find any bias within IR for either IMGs or DOs within the field of interventional radiology?
Yeah, that's definitely a good question. So, um, how I came to actually become an international medical graduate, I had decided early on. My time was a little different when I had applied. I didn't apply to any DO programs. I knew that if I was going to go into medicine, I just wanted to be an MD, because at that time, I did feel like there was some kind of bias towards DO doctors. How things have dramatically changed, it's unbelievable. There is absolutely no bias at all against DOs at this point. Even some fellowships, like one of the cardiology fellowships that I was trying to apply to, the program director was an MD, but it was a DO only fellowship at that time. Now I think I know everything has merged now.
Yeah.
So like there's absolutely, and I've worked with tremendous DOs, not only as attendings, but as co-residents. Like there literally is no difference. But at that point, I had not applied DO. I wanted to apply MD. I got waitlisted at a United States medical school, and I knew that this is what I wanted to do. So I decided, should I wait or should I go for the only other international school that I applied for was St. George's. And the reason why I applied for it was because they had something called the Global Scholars Program. And what that allowed is that instead of you going to Grenada up front, you actually went to England first.
Mhm.
And you spent time in England. You trained with professors that were there at Northumbria University. This was in Newcastle in the United Kingdom, and you trained with the students that were there. So there was medical students that were from the UK there, and then there was also the St. George's students that came in as part of the Global Scholars Program. And that idea, like I born and raised in New York, everything I had done so far, my rotations were all in New York City. All the exposure I had was in New York City. I didn't really venture out. There's enough in New York City that you don't really need to if you don't have to. So I really thought this was a great opportunity, especially when I applied for residency, to talk about how I, got to see. And plus, I was curious myself, how is medicine practiced in other places of the world? So although I knew like, okay, there might be like a chink in my armor, you have a chip on your shoulder. Okay, you're an
Yeah.
IMG. People are gonna look at you in a not so great way. When I came back, everybody wanted to talk about how my experience was in England, what kind of lessons that I learned, and it was the greatest experience for me, to be honest. I get it. Some of these specialties are really competitive, and some places are a little bit looked down upon IMGs. But let me be the first example. Like I was lucky enough to match on my first attempt to internal medicine, and I am an IMG. I I had applied general surgery as well. I interviewed for general surgery, but I ranked internal medicine higher. So I was able to interview for general surgery. As an IMG, I interviewed for cardiology as a potential fellowship. And then I interviewed for radiology and I matched on my first attempt. So I've been through this match process, which is a terrible process, but I went through that process twice. And let me tell you, I'm nothing special. All I've done my entire life is that if I'm interested in something, like I said, I try to get good at it. So which means I'll grind, and that's it. I liked medicine. I knew this was a good opportunity for me to go to the United Kingdom. I didn't wait to see if I was going to get into that United States medical school after I got waitlisted, and I just went with it. And then after that, I just put in the work, and that's what I'm doing till this day.
So in your opinion, what's the best thing about IR?
That's a good question. One of the best things, honestly, about IR is instant gratification. We are so used to, as medical students, as residents, as doctors, delayed gratification is like our middle name. Everything we do is delayed gratification.
Yeah.
But when it comes time for treating patients, I've done it. I was an internal medicine physician attending. Medical management just takes too much time. And I like the fact that in IR, there's a problem. You see the patient, you do what you have to do, and you kind of know right then and there, did you do the job? And patients start to feel better right away. If they have a big effusion and you put a chest tube and you drain it out, you see them right away. They're starting to feel better. And you start to embolize a bleed, and they stop bleeding. Like that gratification for me is what keeps me going with IR. That's one of the things I love about it.
So with that, what's one thing that you wish you knew going into IR that you didn't know previously?
Yeah. So currently, like I said, IR is still in such a state of transition. But as we speak now, IR is still under the umbrella of radiology. So there's diagnostic radiology, and underneath there, there's interventional radiology as a branch of diagnostic radiology. And although I get that, because I said, you have to be good at diagnostic imaging to be a good interventional radiologist, the skill set required is just so different. So when I go to work, like tomorrow, I'm doing primarily diagnostic. The day after that, I'll be doing interventional. The skills needed are just totally opposite. Tomorrow when I go, I'll be looking at images, speaking to clinicians, and dictating high quality reports. The next day, I will go speak to clinicians, consent patients, deal with complications, suture, be more technical with my hands. The skill set is just so different that I feel like sometimes it's really tough to keep the balance. I almost feel like, as bad as it was that I've already finished 3 years of residency and I'm going to another residency, I kind of feel like with diagnostic and interventional radiology, it's like 2 residencies. So I feel like by the time I'm done with this, I'll be done with 3 residencies. That's sometimes how it feels. And that's one thing about IR, which, let's see if as the tide starts to change, how it's becoming a separate specialty. If it turns into its own specialty properly, like a surgery has its own service. Now IR is doing outpatient work. IRs are starting to admit in some places of the country. They have their own service where they admit and don't depend on internal medicine. Maybe the training will change, but as it stands now, IR is a branch of diagnostic radiology. And because it's a branch of diagnostic radiology, you have to be good at both. And it's challenging.
So, is there anything that you don't like about IR?
Honestly, like that's what I would say. I just feel like IR still hasn't found its spot of where it fits into clinical medicine. Everybody knows, and it's always been that way, that IR doctors are clinical physicians. They're more clinically oriented. That's just the way it is. That's the specialty is a clinical specialty. But I feel like because it's under this umbrella of a diagnostic specialty, some places IR is still required to read like high level diagnostic cases at the same time. And it's just so different. You're in a room with a patient, a case that you might think might take 45 minutes to an hour ends up taking 2.5 hours. And then you got to come out and read like a high level diagnostic case of like a brain MRI or, a joint MRI. Like, I just feel like there's a disconnect that needs to be smoothed out. And so we'll see what happens. That's about the only thing, if I could point at anything that's not fun about IR.
So, assuming from what I've heard for the last 30 minutes is, you love IR. So, would you do IR again if you had the choice, or would you go back and choose something else?
No, absolutely, I would do IR again. I mean, I left practicing as a attending physician to go back into training for interventional radiology. The only other thing that would come close would be some other procedural specialty, like a traditional surgical specialty. But the exciting things that you do in IR every single day, and how IR is so dynamic and just keeps changing, I would definitely go back into IR again if I had the opportunity. So I hope that everything works out the way I I'm hoping it does. So currently, I'm still doing diagnostic and interventional, and I hope to transition to interventional eventually.
Okay, so finally, is there any last advice for anyone interested not only in IR, but in the field of medicine or in any healthcare professional? Any last advice you would give to anyone?
Yeah, I honestly, I think one of the most important facets of being in healthcare is you really do have to put yourself out there and ask questions. You really have to reach out to any avenue that you can think of. Like I mentioned before, talking to the nurses, talking to other ancillary staff of things that you don't know, reach out and try to learn them. And you have to really be comfortable with just being like, this is something that I don't know. I'm going to go to somebody who does know it. I'm going to learn it so that next time, I just know it. That mentality, if you keep that mentality going forward, that's going to help you become a great physician one day.
Well, Dr. Rahman, thank you for taking out time of your busy schedule as a resident and taking away time from your family for being on the channel and answering questions and helping future medical students and residents interested in IR. So I really appreciate your time and we hope to see you again soon and best of luck in your journey to IR.
Yeah, thank you so much, man. It was really fun. Definitely, we should do it again. And again, thank you for having me, man.
Yep. Have a good day. Assalamu
Yep.
alaikum.
Welcome, Sam.